Hi guys, I really wanted to do this quick video on hemorrhoids. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at hemorrhoids, also referred to as piles. If you haven't yet subscribed to the channel, please subscribe to the channel. Hit the bell notification icon to be receiving notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's go. And here's a warm-up question, which is a true or false question. Common causes of rectal bleeding include A, internal hemorrhoids, B, anal fissures, C, carcinoma of the rectum, D, all of the above are correct except for B. So keep this question in mind. I will give you the answer at the end of the lecture. You may write it down, you may screen your answer at your screen right now, and we will give you the answer at the end. So before we actually go into details of hemorrhoids, remember that hemorrhoids are part of a group of conditions that are known as painful anal conditions. It's imperative that we actually have to understand the anatomy of the rectum, the anatomy of the anal canal. So remember that the rectum is actually 15 centimeters. It's going to be extending from the rectosigmoid area to the anorectal line. And it curves with the sacrum and actually contains three folds. Now remember that the rectal wall is going to be consisting of a mucosa, it's going to consist of a submucosa, and it's going to be also consisting of two complete muscle layers, pretty much your inner circular layer and your outer longitudinal layer. Then when you talk about the anal canal itself is going to be roughly about 3.5 centimeters long, and it's going to be extending from the anal rectal line to the anus. Now there is something that is very, very important, which I want you to keep in mind, which is referred to as the dentate line or the pectineal line. Why is this important? It's because it's going to be dividing the anal canal into predominantly two parts, an upper part and a lower part. So the upper part, which is above this line, is going to be consisting of columnar epithelium, and it's going to be innervated by the autonomic nervous system. And pretty much this is going to be having, if you have pain or pathology occurring above the dentate line, the type of pain that you're going to be getting is known as visceral pain. Then from the endoderm, you have the lower part that contains, or rather, the upper part is derived from the endoderm, then the lower part is going to be derived from the ectoderm. Now, the lower part is going to be consisting of squamous epithelium, which is going to be continuous with the perineal skin, and it's going to be innervated by the pudendal somatic innervation, the pudendal nerves. So remember that this means that the type of pain that you're going to be getting from this area is going to be somatic pain. So it's going to be a bit different when you get a pathology that's above the dentate line versus a pathology that is below the dentate line. Then you also have columns of Mogagni, which begin at the dentate line and they extend in a cephalad way, they extend upwards. And of course, pain above the dentate line, like I said, is visceral, it's going to be diffuse, it's going to be poorly localized, while the pain that's going to be below the dentate line is going to be somatic and it's going to be well localized. So within the anal canal, you have these anal sphincters, which are just these part of the muscles. So you have two types of sphincters. You have what is known as the internal sphincter and what is known as the external sphincter. So the internal sphincter is going to be under the control of the autonomic nervous system, so you have no control over it. The external sphincter is going to be under voluntary control, so you can actually control it via the pudendal nerve, which is S4. So when you look at the internal sphincter, it's just pretty much circular muscle, which is continuous with the inner circular muscle smooth layer, and it's going to be innervated by the parasympathetic nervous system. Then, of course, the external sphincter is going to be blending with the outer longitudinal skeletal muscle layer with three parts. It has a subcutaneous part, it has a superficial part, and it has a deep muscular part. Now this is going to be under the voluntary control and is going to be innervated by the pudendal nerve. Remember that the superior border of the external sphincter is going to be fusing with the puborectalis muscle, which actually forms a sling originating at the pubis and joining behind the rectum. Now, the space that you actually have between the internal and the external sphincter, which is known as the intersphincteric plane, consists of this fibrous continuation of the longitudinal smooth muscles of the rectum. And normally you have about 6 to 10 anal glands that are going to be lying in this space. Now, each of these ducts is going to be pretty much discharging into the anal crypt of the dentate lines. Now, remember that when there's an infection that can actually happen, the infection can actually originate from these glands, and that's how we're going to be having things like abscesses. We're also going to be having things like fistulas in anal fistulas or fistula in anal. So here's a cross section of the anal canal and the lower rectum. Pretty much going to be showing you the important anatomical relations of the region. So as you can see here, these squiggly lines that you have there, those are the lines at the anal valves or the anal verge, or you can think of it as a dentate line. So above this is somatic pain, below this is below is somatic pain, above is visceral pain. Then here you have your internal sphincter, here you have your external sphincter, and in between is a space which is known as an intersphincteric space, which pretty much has those glands which are going to be secreting their contents into the lumen of the rectum. Now, let's go into details about hemorrhoids or piles. So remember, the word hemorrhoid actually comes from two words. It comes from a Greek word meaning hema, meaning bleeding, and rhos, meaning flowing, so meaning bleeding. So it means that if you have a hemorrhoid, you're pretty much bleeding. And we can also use the word piles, which is actually derived from Latin, meaning pillar, meaning ball. So it's like a mass, a ball or a mass, and hemorrhoids is like blood oozing out. So it's a ball of mass that is going to be in the rectal area that's going to be oozing out. So remember that the anal canal is pretty much going to be lined by these structures which we refer to as anal cushions. Now, these anal cushions are going to be just pretty much thick vascular submucosal bundles. They are going to be functioning in aiding in continence, maintaining the anal tone. They also engorge during defecation and actually even protect the anal canal from abrasions. Of course, the actual function of these anal cushions is not so known. It's not so clear. So you have them predominantly in three main areas. You have them at the 3 o'clock, you have them at 7 o'clock, you have them at 11 o'clock. So if we were to draw a watch over here, so let me suppose I draw a watch over here. You have your 12 o'clock over here, you have your 6 o'clock over there, you have your 9 o'clock over there, you have your 3 o'clock over there. So this is a person that's in lithotomy position. So you have 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock. So it's going to be at 3 o'clock here, which is going to be your left lateral position, because this will be the left side, this will be the right side. So it's going to be at 3 o'clock. It's going to be at the right posterior position here, because this is the posterior aspect, this is the anterior aspect on top. So this is going to be 7 o'clock over here, and then also the right anterior lateral, which is 11 o'clock. So these are the positions where you get these anal cushions. That's where you actually expect the hemorrhoids actually from coming out. Now, remember that these same hemorrhoids are going to be pretty much downward sliding of the anal cushions. This can be as a result of straining or even other causes. And remember that these anal cushions, like I said, are blood vessels, aggregations of blood vessels. You have arterioles, you have venules, you have smooth muscles in there, you have elastic connective tissue in the submucosa, and of course these are going to be normally residing in those three characteristic positions: the left lateral position, which is the 3 o'clock, the right posterolateral position, which is the 7 o'clock, and the right anterolateral position, which is of course our 11 o'clock. So they're going to be found at 3 o'clock, 7 o'clock, and 11 o'clock. Now, when you talk about a hemorrhoid, this is simply going to be consisting of a dilated venous plexus, pretty much a small artery, and areolar tissue. So these can either be of mucosal type or they can be of vascular type. Vascular type meaning that it has more blood vessel, a more blood vessel component. It's much more common in the young individuals. Mucosal meaning that it's mostly just mucosal, not so much blood vessel. This is common with the older patients. Now remember that the present concept is that there's going to be a weakening on Park's ligament, which is the lower end of the external sphincter. Now this is just the clocks that I already explained. 11 o'clock, which is the right anterior, 7 o'clock is the right posterior, 3 o'clock is the left lateral. Now hemorrhoids can either be internal, external, or internal, external, so meaning both, mixed. So internal meaning that it's going to be above the dentate line or above the pectineal line. So these are going to be often covered with mucosa. These are internal piles. So the only symptoms that they may get is maybe bleeding when they go open bowels. Then the external piles are pretty much going to be below the dentate line. So these ones tend to be quite painful because remember the somatic innervation below the dentate line. And then it sometimes can be a mixture of both internal as well as external hemorrhoids. Now, we can classify hemorrhoids based on their location. We can also classify them based on their severity. I'll give you a grading system very shortly. So when you talk about the locations, those that are going to be occurring at those primary places where you have those anal cushions at 3 o'clock, 7 o'clock, and 11 o'clock, then these are going to be referred to as primary hemorrhoids. Because remember that these are going to be branches of the superior hemorrhoidal vessels, which are going to be dividing on the right side into 2 branches and on the left side into 1 branch. Then anything that is occurring between these 3 locations, we refer to that as a secondary hemorrhoid. Then when you talk about severity, this is just pretty much the extent of this hemorrhoid. So we have our first degree where the piles are just present, but they do not prolapse. They're just bleeding. They do not come out. It's just blood, what we refer to as a splash in the pan. Then second degree is where the piles are prolapsed during defecation because there's increase in straining, and then they return back spontaneously. They don't have to be reduced manually. Then the third degree is going to be the piles that are going to be prolapsing during defecation, but they should be replaced back manually. They can only go back manually. Then fourth degree are the piles that are permanently prolapsed. These ones even carry a risk of thrombosis. Now, what is going to be causing hemorrhoids? So pretty much they can be hereditary. In some of the cases, they are idiopathic. Now, remember that before we talk about the different causes, the morphological things that you have to keep in mind. The morphology. Remember that the weight of the blood column in the blood vessels that are in the anal canal, those blood vessels are not going to have valves, and this is going to be means that there's going to be high pressure in these vessels, and the veins in the lower rectum are going to be in the loose submucosal plane, but then the veins in the the veins above enter into the muscular layer, which on contraction increases the venous congestion below. So it means that there will be blood that is being pushed back, and this is much more evident when someone has some constipation. And then remember that the superior rectal veins have no valves, as they are tributaries of the portal vein, so there's more congestion in these vessels. Then other causes are going to be including straining, diarrhea, constipation, hardened stool, low fiber diet, overpurgation, anything that is leading to increased intra-abdominal pressure. You could have carcinoma of the rectum, portal hypertension, but these are rare causes. Pregnancy also is a cause of hemorrhoids. Remember that with pregnancy, you have high levels of progesterone, which pretty much relax the venous wall. They reduce the muscle tone of smooth muscles, and even just the enlarged uterus can sometimes compress on the pelvic vein, and constipation is also a big problem with pregnant women. Then what are the clinical features of someone who has hemorrhoids? They generally are going to be between the age of 30 to 65, but they can occur at any age. The incidence is equal in both genders. Now, one of the first symptoms that they get is this painless bleeding, which is what is referred to as a splash in the pan. So they have this bright red and fresh blood that is going to be there on defecation. Then, of course, the mucus or the fecal soiling may sometimes occur, though in general, they get these changes in bowel habits, which are not so common, and they should allege to other causes if you get this fecal soiling or even a lot of mucus. Then they may feel a mass in the anus. There may be a discharge that may be mucoid. They may have pruritus, which is itching. Sometimes there is pain. Pain usually occurs when there is prolapse. It occurs when they are infected. It occurs when there is spasms. Now remember that prolapse of an internal hemorrhoid may actually produce moisture in the anal region, or even a mucus discharge that's going to be causing itching. Then, of course, they may have anemia because this person is chronically bleeding. This is a secondary type of anemia, most commonly iron deficiency anemia. When you perform your examination on inspection, you may be actually able to visualize the prolapsed pile. On the digital rectal examination, only the thrombosed piles actually can be felt. What's our differential diagnosis? It could be carcinoma, it could be a rectal prolapse, it could be perianal warts, and there are different other causes that may cause someone to bleed from the anus. So it could be hemorrhoids, which I've already talked about, anal fissures, anal fistulas, which we will talk about, polyps, ulcerative colitis, amoebic colitis, carcinoma of the rectum and carcinoma of the colon, diverticulitis, intussusception, vascular anomaly of the colorectum, and even mesenteric ischemia. These are just other things that you should keep in mind. Now, how do you make a diagnosis? What investigations are we going to order? First and foremost, we get a proctoscope where you can actually be able to denote the number, the degree, the size, the surface, and even the appearance of the piles. And of course, the features of chronicity of the prolapse. Then you may also do a sigmoidoscopy or a colonoscopy to rule out malignancy, and endoscopy to rule out any other cause of sources of rectal bleeding, for example, cancers or even inflammatory bowel disease, which could be coming from the upper GIT or bleeding with severe extent. Then you may also do a barium enema if you want to ruling out any malignancy. A full blood count should be done to check out the level of the hematocrit and hemoglobin in cases of anemia, and as well as the platelet count. Do not forget to cross-match these individuals because they may require a blood transfusion. I remember once dealing with a patient that had a very, very low HB, and this patient had an HB of 2. Then what are the complications? They may have profuse hemorrhage, which may require blood transfusion, like I told you. Strangulation happens. This happens by the anal sphincter. Thrombosis can happen, so the piles actually are going to be appearing dark purple. They may be black, and they'll feel solid and they become tender. These are features of thrombosis, and this is of course an emergency, and you have to operate on this patient. There may be ulceration, there may be gangrene, there may be fibrosis, there may be anal stenosis, there may be suppuration. So this can actually lead into a perianal and even a submucosal abscess, which is why when we come to the management, I will explain certain things that you can do if you have hemorrhoids. Then, of course, you may have pyelophlebitis, which is portal pyemia. It's a rare complication, but it occurs with third-degree piles after surgery. Now, what's the treatment of hemorrhoids? So generally, if you have external hemorrhoids, you're going to be treating them with analgesia, sometimes warm soaking. Then, of course, if the pain is severe and if they're thrombosed, they must be cut. They must be excised. If there's mild bleeding and protrusion of the external hemorrhoids, then this can be controlled with some conservative treatment involving avoidance of foods that cause constipation, increasing the fiber diet, and of course, using bulk-forming stool agents. So the above measures can actually resolve all the symptoms. In some cases, if it's conservative management, we can actually manage the hemorrhoids. Then you may sometimes perform rubber band ligation, where you're going to tie off the hemorrhoids. This can be used in first and second degree hemorrhoids. Sometimes you can inject phenol or even almond oil, which can actually play a very similar role. Now with the third and fourth degree hemorrhoids and the mixed internal external hemorrhoids, these ones require surgery. So they require hemorrhoidectomy. So here's a table to summarize everything that I've been talking about. So the preventive measures is of course diet. So we increase the fiber, we increase the liquid content in the diet, we may use some laxative. There are some medical therapies that we can do. Sitz bath can be done. So we just immerse the anal region for about 15 to 20 minutes for about 2 to 3 times a day. And of course, you can get some warm water that has some salt in it. You may sometimes add some antibacterial agents. Some cases, you sit in these things for 2 times a day. Sometimes you can sit in this for 3 times a day. This helps with reducing the edema. It helps with reducing the pain. It helps also with promoting the healing. You may also have some analgesics. You may have some local anesthetic creams that you can apply in the area. Some antihistamines can be applied. Antibiotics should be taken to prevent an infection if there is a risk of infection or if there is some signs of an infection. Then of course laxatives can be taken to clear out the bowel, and a local anesthetic and an anti-inflammatory drug like Anomax, which is a suppository, can be used. Then you have a parasurgical way, which you can use other modalities like sclerotherapy, banding, where you tie them off. This is quite common. You may sometimes even excise them in theater. You may use infrared coagulation. You may use laser therapy. You may use a Doppler-guided hemorrhoidal artery ligation. This is actually good for pregnant women. It's good for diabetic patients, because remember that in diabetic patients, wounds don't heal as normally as those that are non-diabetic patients. Now, there is a surgical approach. There is an open hemorrhoidectomy that can be done. That's a Milligan-Morgan procedure, which was made famous in Britain. Then you may have a closed hemorrhoidectomy, which is the Hill-Ferguson procedure, which was made famous in the USA. Then you may have a stapled hemorrhoidopexy, which is by the Antonio longo procedure. You may also have anal stretching that can also be done. These are just different surgical modalities that can be taken to manage patients with hemorrhoids. Now, why am I mentioning this? It's because you can actually tailor the treatment based on the degree of severity. So remember, first degree, they haven't yet prolapsed. This person is just bleeding. So you pretty much just want medical interventions are usually just enough. You're increasing in fiber diet, you're increasing use of laxative, avoiding constipating foods, and sometimes a sitz bath. This can just be enough. We can also offer parasurgical treatment where we can give them sclerotherapy. We can also use the Doppler-guided hemorrhoidal artery ligation. Then if it's second degree where they prolapse but on defecation but they return spontaneously, medical interventions are also usually enough, but you can do sclerotherapy. You may do Barron's banding. You may also use your Doppler-guided hemorrhoidal artery ligation. Then for third degree where they prolapse but have to be reduced manually, and fourth degree where they are prolapsed permanently, medical interventions can help the patient, especially before surgery, but generally these patients have to be treated by our parasurgical and surgical modalities. So laser therapy, Doppler-guided hemorrhoidal artery ligation, hemorrhoidectomy can be the gold standard for both of these cases. Now here is our warm-up question. Common causes of rectal bleeding. A, internal hemorrhoids. This is true. B, anal fissures. This is true. This was part of the differential diagnosis of rectal bleeding. C, carcinoma of the rectum. This is also true. And then that would make D as all correct except B as false. I really hope you enjoyed this video on hemorrhoids or piles and you learned a lot. If you did, consider subscribing to the channel. Hit the bell notification icon to never miss such amazing content. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.